Welcome.
I'd like to start by introducing myself to your group. As you can see from my first slide, my name is Phillip Sarrel. I'm an emeritus professor in OBGYN, reproductive sciences and psychiatry at the Yale University School of Medicine. I've been asked to talk to you about estrogen. I actually have been a student studying papers about estrogen since 1960. I was introduced to estrogen when I did a student fellow assignment to the Department of Endocrinology at Mount Sinai Hospital. And there I participated in a study in which estrogen, hydroxyprogesterone acetate, testosterone, and a placebo were administered to breast cancer cells. As it turned out, there was one kind of cell whose reproduction was increased by the addition, and those were the cells receiving hydroxyprogesterone acetate. There were other cells that were inhibited and killed by the substance being fed to them, and that was the cells that received estradiol. Isn't that fascinating? Here we are 65 years later, and I'm still a student of estrogen and how it works and where we might use it in our everyday practices. Estrogen Matters is the title of a book by, by Avram Blooming and Carol Tavris. I'll tell you more about that at the end. This presentation includes information about estradiol's chemical structure and measurement, estrogen receptors in the cells in which growth, replication, apoptosis, and everyday function are affected by estradiol, the effects of estradiol deficiency after natural or surgical menopause, estradiol replacement for symptom control, prevention of disease, and extension of a longer and healthier life. I'll say something at the end about the use of estrogen in women with a history of endometriosis, but let's wait until we get there. One of my favorite readings is this wonderful article by Santon and Simpson in Endocrinology in 2019. In a sense, it tells you everything you wanted to know about estrogen, but were afraid to ask. They cover the whole history, thousands of years of history of people aware of a substance being produced by the ovaries that caused femininity, but no one knew what it was. The conclusion that Santon and Simpson reach is that the history of estrogen illustrates the role of intellectual reasoning, motivation, and serendipity in advancing knowledge about this important sex steroid. It also tells the history of controversy, and we will say more about that. 1920 to 2002, so if we go back 100 years, we see really the beginnings of the modern era. It was known by the late 1880s and 1890s that if you took the ovaries out, women reacted with hot flashes, with urogenital atrophy, with psychiatric reactions. Something must be being produced by those ovaries, but nobody knew. It's only in 1923, with Allen and Wassey's presentation of their findings, that we understand there is a hormone. In fact, they discover more than one estrogen, and they then start to show us its structure. It's interesting that they found that in 1923. 1921 is the discovery of insulin. I'll also talk about important milestones in the history of estrogen. So first is its discovery. Second is the ability to measure it. Remember that estradiol circulates in very tiny amounts, picograms, a thousandth of a milligram. Diallo and Burson developed radioimmunoassay and the ability to measure estradiol. In science, measurement is absolutely a key to understanding what a particular substance is doing. In addition, identifying and knowing how much to make led to micronization so that we could then have an estradiol that could be used clinically. I mention Elwood Jensen because he was the first to come up with the concept of steroid receptors. And he publishes that in 1962. It was extremely controversial, and he was mocked. How could there be such a thing? Well, what you see 40 years later in his paper with V.C. Jordan is a history of the discovery of the receptor, not only in the nucleus, but in the cell membrane, and all the different actions. So these to me are four key papers that everyone should be aware of and, and read and draw conclusions for their clinical practices from. Now, the search for ovarian hormone, as I said a moment ago, it really begins in the late 1880s and 1890s, but by the 1920s, we had the hormone. We knew about estradiol, we knew about estrone, and we knew that there was a major difference in women who had a natural menopause versus women who had a surgical menopause. The earlier concerns were about the women with surgical menopause. We knew that it was being made in the follicle, whatever this hormone was. Now, by the 1960s, it was clear we were dealing with estradiol, and that there were dramatic changes in production of that in a woman's body. The first paper by Allen and Doissy, and subsequently there was a test called the Allen-Doissy test, showed the structure, simple, straightforward, steroidal structure, which you all know inside now. What you may not know is that estradiol was the very, very first steroid hormone to evolve 600 million years ago. Estradiol was being used in species to sustain biological life. I also mentioned butanant because the Germans discovered it about the same time, and butanant was given the Nobel Prize for the discovery. But that's the structure we're talking about. Then along came Rosalind Berso and Rosalind Yalow and Solomon Berson, and they too ran into major controversy. The first paper that they wrote on radioimmunoassay, submitted to the Journal of Clinical Investigation in 1957, was rejected. How could you do such a thing? It doesn't make any sense. Well, it made a lot of sense, and they prevailed and eventually did wind up with a Nobel Prize. Now that we could measure the hormone, you can see in this slide, for example, the levels of estradiol that are present in a woman from the onset of puberty until she reaches. I was saying that once the hormone had been described and a way of measuring it could be reproduced, it was possible then to describe the levels of estradiol that are normal in the reproductive age, what happens in natural menopause, what happens with surgical menopause. For this presentation, we won't go to testosterone, progesterone. Let's just stick with estradiol. Bear in mind that average level of 150 pgs per ml. Some others have said 200, some have said a little less. But most important thing to keep in mind is that during her reproductive years, a woman is producing estradiol every single day of her menstrual cycle, including when she's menstruating. At that time, the next follicles are responding and producing estradiol of their own. But this will also give us an idea of what estradiol replacement would look like. Once you know what you're dealing with, then you can be more precise in your medical care. Now, following radioimmunoassay actually developed about the same time was the concept of the estrogen receptor. And as I mentioned a couple of minutes ago, this was very controversial. Those in the know put Jensen down, but he prevailed and he was right. There's an excellent discussion and understanding of the estrogen receptor by Leon Spiroff. This is in the Annals of New York Academy of Science, and he just spells it out for you. So let me just repeat very simply what Dr. Spiro had to say. Understanding the estrogen receptor. The reaction of tissues to estrogen is due to the presence of specific proteins inside the cell and in the cell membrane. It works like this. The hormone diffuses from the bloodstream across the cell membrane and enters the cell. It binds to the receptor protein. The combined complex interacts with DNA in the cell nucleus. A messenger RNA, is synthesized and is transported in the cell to ribosomes. And finally, proteins are synthesized in the cytoplasm that result in specific cellular activity. And we will start to look at some of these specific cellular activities and the cells in which all of this is going on. I might say, as an aside, but an important one, practically every cell in the body has the mechanism for using estradiol. In this model, you see the hormone. It's not exclusive to estradiol, but estrogen does enter the cell, attaches to the receptor, and induces the messenger RNA changes that Spiro was just describing. What we can then do is, once you have the ability to identify receptor activity, then you can find the target tissues. And here's a list of all the target tissues. I drew up this list when in 1996, so since then, many other areas have been found. But as you see, it's pervasive. The hormone is working from the brain to the liver, the kidneys, everywhere in a woman's body. So it's not just limited to one specific area. It's everywhere that it's working. Isn't it amazing that over the course of evolution, that there would be such a substance that could sustain function in such a wide variety of cells and organs? But that's the case. I would say, most extensively studied have been the actions in the cardiovascular system. It was seen very early on that loss of ovarian function, and that in turn meant loss of estrogen production, led to an increased risk for cardiovascular disease. And very early on in this story are the studies from the Mayo Clinic showing young women in their 20s, who'd had their ovaries removed without any hormone replacement, suffered usually within 10 to 11 years from a myocardial infarction. But all of these actions, actions that have to do with lipids, that have to do with antioxidant effects, I think extremely important clinically to know and understand is the nitric oxide effect of estrogen, the calcium effect of estrogen, and the effect on constrictor agents and acetylcholine. In 1980s, American Heart Association published a book on estrogen actions in arteries, and there were almost 1,000 papers published. Classic were the studies on the effects on lipids. It's extremely potent in inhibiting the deposition of cholesterol, preventing calcium from building up in the wall of the artery. And the coronary calcium test has now started to become a standard test for determining, number one, if there is progression in a woman, especially young women who've lost their ovaries, and if estrogen treatment is helping to prevent that progression. I included this slide because I wanted to go back to the story from the Mayo Clinic. Look at the date when it's published. 1953 is Woost's paper. They had 20 subjects all together. Patient number one was a woman who lost ovaries when she was in her early 20s. She was 23 years old. She was a nurse, and she actually died from a myocardial infarction at age 28 when they examined her, she had extensive disease. In their series, they found that if a woman had lost her ovarian function, these were surgically menopausal women, before the age of 60 and had no hormone replacement, their life expectancy after, especially after bilateral salpingo or oophorectomy, was 11 years. That was no matter how young the women were. Another major study is the Seattle study, Rosenberg's study, in which he showed that if women who had oophorectomy, 35 years of age or younger, without any hormone replacement, the increased risk for coronary heart disease was almost 800% increased. These are early findings, but they're helping us to understand the importance of the actions and of the hormone in the cardiovascular system. But let's move on to others. If we jump forward from the 1960s and 50s and those early studies into this century, the new and exciting area, let me tell you, for the 65 years that I've been studying estrogen, there's never a dull moment. There's always new and interesting things being found. The focus now is on the brain. This paper by Jett and Shellbaum, which was only published 2 years ago, it's a paper you should all be aware of. And their conclusions in reviewing all of the literature on estradiol and the brain, they call it the master regulator of the female brain. And it's due to its wide range. There's no part of the brain unaffected by estrogen. Its effects are on neuronal structure and is also on blood flow to the brain. It basically plays a neuroprotective role. And that turns out to be important with respect to cognitive aging and Alzheimer's disease. Another good reason for you to know about this paper is the references. I have the paper actually in front of me on my desk. There are more than 300 references to estradiol and actions in the brain. One of the most interesting of those is a paper from California just a couple of years ago, in which they looked into what happens to the process of nitrosylation in neurons in the frontal cortex during hot flashes. And what they show you, very importantly, and Stuart Lipton is one of the most important investigators in the country on Alzheimer's disease. They show you the destruction of neurons that occurs during severe hot flashes. So this is the kind of work that modern technology has made possible. We can understand what's going on and what the effects of depletion are from top to bottom in a woman's body. And it's quite extensive. In fact, there are thousands of biological effects of estradiol. It stimulates cell growth, as Spirov pointed out to us, reproduction, and the death of cells. And here's another really important study. This is from the Harvard group, Carol and Myers group in Nature Genetics. And this is a study of breast cancer cells and looking at the effect of estradiol on breast cancer cells. Well, it turned out that in their findings, there were 3,600 effects of estradiol on a breast cancer cell. More than half of those effects induced the death of the breast cancer cell. That's important to know because everybody's worried about estrogen and breast cancer. The fact of the matter is that it's a balance of effects. If we look at the more recent studies, and I've tried to summarize some of the most important ones on this slide, you look at the studies of, well, what actually happens with respect to breast cancer if you give a woman estrogen versus placebo? Well, the bottom line, as I put in quotes, and this is drawn from the Women's Health Initiative and the Danish Osteoporosis Prevention Study, the DOPS study, is a major reduction in mortality from breast cancer in the women who received estrogen. The two sisters study, an NIH study, they compared the sister when one sister had developed breast cancer and what happens to her sister if she took estrogen or not. And it turned out the sisters who took estrogen had a lower risk of developing breast cancer. So if you're locked in your thinking that estrogen causes breast cancer, I would strongly urge you to delve into this literature. On this slide, the second reference, V.C. Jordan. Remember, V.C. Jordan is one of the pioneers in the development of tamoxifen. And in a 1988 paper, which was one of those papers I read when it came out, because remember, I was studying all I could about estrogen. One of the things that V.C. Jordan said was, in tamoxifen, we have a new compound which has estrogenic effects, but does not stimulate the endometrium. And he states, the tamoxifen is almost as effective in preventing breast cancer as estrogen itself. That's a direct quote from a medical oncologist who's the pioneer in the field, who unfortunately died within the last 6 months. At any rate, here's a whole list of references for you on why estrogen can be used to protect women's breasts. What happened in the course of evolution was the development of several basic cellular responses to estradiol, which really spell out biological existence. In my list, what I think are most important is the induction of nitric oxide and all the actions you'll ever learn about that. The control over epinephrine and norepinephrine, catecholamine. There are catechoestrogens. Catecholamines are modulated in their release. And of course, without estrogen, as in a hot flash, you have this uncontrolled release of both hormones. They also have a direct effect on intracellular calcium levels. I had the privilege, that's reference 4, to participate in a team that did single cell studies to show that estradiol was a calcium channel blocking agent. But something else to know, which can be quite important clinically, is if you look at the fourth of my main points above, its effect through the liver on binding globulins, on thyroid binding globulin, on cortisol binding globulin, on sex hormone binding globulin. Estradiol is a major controller of hormones in the body. And that I don't think is widely recognized, and it should be. Now, how did these all come about? Because we know, and I threw in the octopus so I would wake you up, the octopus is so interesting to study. The octopus is unchanged over a period of 600 million years. It's extremely smart. It can solve mazes. You put it in a jar, it can open the jar from the inside. It can recognize people's faces. Its skin color is affected when it's in danger. Most interesting to me is, as you know, it's got 8 arms. And at the end of those arms, at the top of each arm is a brain. So it's got 9 brains. But it's also at the end of that arm, it is so highly developed that it has sensors that can find molecules. And it's been demonstrated that the octopus will search for estradiol and take it into its body through the receptors at the end of the tentacles. And in its body, it turns out that it's very important in the octopus's brain, learning, motor coordination. It induces the production of nitric oxide in the octopus. So all those things that we see as so important in today's science as to what makes a healthy body. The octopus was the pioneer. We can see that now this hormone, which has persisted for 600 million years, has induced these changes in species after species after species, and it works. Okay. What happens when there is a depletion at menopause? Symptoms develop that affect everyday function. There is an increased risk for major diseases. I'll spell them out for you in a couple of moments. And there's an increased mortality prior to age 70. Women who've lost ovarian function before age 50, who don't get estrogen replacement, have an increased risk of dying of a heart attack before the age of 70. The women who suffer the most are the women you in the endometriosis field are working with all the time. It's women whose menopause is secondary to surgery. And of course, there are also the actions before the surgery in which the endometriosis has affected ovarian hormone production. So for those women, it's a double whammy that in terms of not having adequate levels of this hormone that's so vital to biological existence. What about hot flashes? Here's a few things to just review with you, because a hot flash is not just getting hot. Millions of women have them, of course. We're going to look at, we can't look at all of the effects in the course of the day, but I want to say something about workability since that's so important in today's society. But we do know that women who develop hot flashes compared to women who don't, let's say with natural menopause, 30% of women don't ever have a hot flash. Well, the women who do have increased risk for developing hypertension, developing diabetes, cardiovascular disease, osteoporosis, and brain disease. The women, especially when you have that history of severe hot flashes, it increases the risk for all of those. We'll talk about estradiol replacement. It's the only therapy that will control the symptoms and reduce risk and reduce mortality risk. And as I say, and I can't say it enough time, the greatest benefits are seen in women after hysterectomy who receive estradiol replacement. The prevalence is different. With natural menopause, 40 to 70% experience hot flashes. With surgical menopause, it's more than 90%. In the California teachers study, it was 96% of the women after surgical menopause experienced moderate to severe hot flashes. So we're talking about millions and millions of women having this experience. Many of you have probably seen this slide. It's really an important one because it's showing you what a hot flash looks like. On the left is the woman with her skin temperatures. And if you look at the bars on the bottom of the slide, the red is a lower temperature, the white is the highest temperature. Look at how her face becomes white hot when she has the hot flash. And she feels it most in her face and on top of her head. Also in areas of her chest where there are a great many temperature receptors. When you heat the skin like this, you increase its blood flow. And during this experience of a hot flush, 20% of the total blood volume in a woman's body is shunted to her skin. That's a major physiological event, to have all of your blood internal flow reduced because it's going out to the skin. Dr. Freddie Cronenberg, who passed away, must be a decade at least by now, did a major study of what do women experience during a hot flush. This was done at the Columbia Presbyterian Hospital in New York, and it's over 900 women. Yes, of course, if you go down the column on the left, the women did feel hot. They had sweating and flush. But look at the 40%, 42% who are experience pressure in their chest. In the surgically menopausal women, it can become quite severe, feeling very anxious, feeling embarrassed or depressed. In Cronenberg's study, 9.5%, go to the red column, go down right to the bottom of it. You'll notice over 40% of the women feeling depressed, but almost 10% of the women having suicidal thoughts. My experience, because remember, I also work in psychiatry, it's not been unusual to see women having hot flashes and feeling suicidal and needing reassurance that this is part and parcel of her body's reaction to the loss of hormones. We studied the symptoms that developed at menopause. We took 3 years to do this study at Yale. And what we were interested in finding out were what were the symptoms that developed at menopause, did not respond to placebo, but did respond to estradiol, the estradiol level being between 40 and 50 pgs per ml is what we gave the women. And what we did find was here's a list. Yeah, I know that there are lots of symptom indices. This is just one of many. I think they were all fine. This was one of the earlier ones. We published this in 1990. Of all the symptoms on the list, the palpitations, the headaches, the sleep disturbance, numbness, what do you think was the most upsetting to the women? The answer is memory loss. It's that problem of starting a sentence and not remembering the end of the sentence or name recall. It's very frightening, especially in an era when we're so aware of dementia and Alzheimer's disease. And once the women learn, no, we understand this problem of memory loss related to menopause. It is related to the hormone deficiency. It's going to get better. And I'll show you our data. There were also the sexual issues. And then at the bottom of our list, as a result of spending the years that we did doing this study, we realized work was very, very important in the women's lives. And we should understand how the hot flashes were affecting them work. So I've already described this slide. We'll go on, and that's the publication of it. There were symptoms that affected work: sleep disturbance, the hot flashes, anxiety attacks, depression, memory effects. Look at how frequently these were occurring. So the women were saying, yes, I don't sleep well. I fall asleep. 2 hours later, I wake up and I feel wide awake. And then I go back to sleep. And then I wake up another 2 hours later. And I can't. So by the time I wake up in the morning, I'm very tired. I'm tired all day. It definitely affects my work. And you'll see down this list, if we go on to the next piece of our work, we had pre-hormone therapy and post-hormone therapy findings on symptoms that affected work. Trouble remembering. 82% of the women were describing that prior to being treated with either placebo or with estradiol. At the end of 6 months, look at the drop down to 26%, or disturbed sleep from 80 to 10%, or checking and double checking going from 46% down to 8%, or temper outbursts. You can read the list as well as I can read it to you. This is a very important aspect of a woman's life. Half the workforce in the United States is made up of women. And what we know is that these women with hot flashes will go to work. And in this study, a separate study, we studied the health records, the insurance records. How much were the companies paying for the women's health care? We studied the records of 13 million individuals working for Fortune 500 companies. And out of that, we were able to find of 250,000 women who had hot flashes versus 250,000 women who didn't hot flashes. And then we could measure how many healthcare visits the women had and what their work loss was. And what we found was in this 250,000 women going to work with hot flashes in the course of a year, they had 1.5 million more outpatient visits than the women who didn't have hot flashes. What a healthcare burden that starts to add up to when you think of the many millions of women walking around with hot flashes and trying to go to work. The costs are enormous. Bottom line, the total cost just for this 250,000 women came to $400 million in 1 year. So I wanted to make that little bit of a spiel for you because ordinarily in everyday practice, you don't think about the impact on work, but it's very important. In the UK, a study a couple of years ago showed that 20% of women doctors in the National Health Service were quitting work because of menopause symptoms. So it's affecting anyone and everyone. The next thing that I would like to turn to from symptoms is disease, because ordinarily people, well, not ordinarily, but people have traditionally said, well, what's the big deal about menopause? It's just a matter of symptoms. No, it's not just a matter of symptoms. The symptoms are like the canary in the coal mine. They're a signal that something really important is going on in the body, and you better pay attention to it. And what we'll talk about now in this next section of my presentation is disease that's related to estradiol deficiency and its effect on mortality. There are disease markers that you can study to look for the effects of estrogen deficiency that could affect disease. I already mentioned carotid and coronary calcifications. Carotid intima thickness is another measure. Endothelial, the endothelium produces nitric oxide that keeps our arteries open and keeps us alive. That is impaired. I spent several years of my life studying the effects on nitric oxide production, but also effects on glucose, on sympathetic tone. All of these papers refer to it. Even loss of bone is increased in women who have hot flashes versus women who don't. So whatever you do, whatever you think about using hormones, if you have a patient who's got hot flashes, the primary thing is to bring them under control because their phenomenology is affecting the body in many different ways. This is a paper you should all read. It's Gruber's paper in the New England Journal of Medicine in 2002. And in that paper, their team points out very clearly all the different conditions. Periodontal disease is affected to estrogen deficiency. It has to do with blood flow around the tooth and how that is decreased and leads to necrosis and infection in women who are hypoestrogenic. But the list goes on, and you can see how, if you go down this list, cardiovascular disease, breast disease, osteoporosis, urogenital atrophy, sexual dysfunction. At the top of the list, the central nervous system and the vasomotor symptoms. But it's an extensive list, and as I said earlier, practically every part of the body. And that's what Gruber's article points out to you. And that was in 2002. 2002 is a major turning point year, as you know, because that's the year when the WHI was first published and everybody started to run away from using estrogen, just when we knew how important it was. The diseases that have now been shown unquestionably to be reflected. Osteoporosis, that's in the previous slide. Let's see if I can go back. The last reference on that slide is to Fuller Albright's paper on postmenopausal osteoporosis. Fuller Albright was one of the people in the room when the estrogen receptor was first described, and he believed what was being said. And then he went on to show that osteoporosis was related. But here's your major diseases, all of which are related to estrogen deficiency. And it's quite an important list because it's big diseases, not little diseases. We'll look at some of the data. We can't look at it all in a short presentation. But the bottom line, which I've bolded and underlined, is that the most severely affected are women who are estrogen deficient and are under age 50. And half of the women who are menopausal under age 50 are menopausal because of surgical menopause. Remember, half of all hysterectomies are done by age 45. Now, looking at the increase in disease with surgical menopause compared to natural menopause, that's an important list for you to know and understand. The risk for osteoporosis and hip fracture is doubled. The risk for having a heart attack is doubled. Hypertension and stroke is increased. Depression, dementia, and Alzheimer's disease are all increased. I showed you the earliest slide from the Seattle study with the increase 7.7%. Suicide risk is more than double in women who've had young age, loss of ovaries without hormone replacement. That's the list. If we go to the Mayo Clinic study, it's one of 4 major studies Mayo Clinic starts in 1988, but it's one of four major studies across the country that have been looking at cohorts of women for over 30 years. And what do they find? If a woman's age 45 or younger and she has no hormone replacement, and Dr. Fobian's study, Stephanie Fobian's study paper is an excellent for one for all of you to read and think about. The increase in osteoporosis, in heart disease, and stroke, in cognitive impairment, and mortality. And you see the figures spelled out for you. So surgical menopause, major problem, something we need to do something about. Now, the Women's Health Initiative, with its initial report in 2002, I'm not going to go into that. You can that probably all of your lives, professional lives. But the issue here is disease and death. So let's look at that. After the WHI papers were published, first paper was published in July of 2002, there was this major drop off in women using hormone replacement. It dropped down to about 4% afterwards versus about 40% before. And this, first of all, with respect to osteoporosis, it showed up immediately in osteoporosis. The development within 2 years. And what's happened then since then, so if we go to Karim's papers, you'll see that there's been this major increase in hip fractures. That's not a small problem because the increase in risk, as you can see from the bottom line, goes from 3.9 in 1,000 to 5.67. So it's almost a doubling of the rate of hip fracture. In this slide from Karim's paper, start at the left side of the slide, and that's showing you hormone therapy use in 2002 before the WHI. Then bingo, out comes this very frightening paper with a tremendous media coverage of it. So very rapidly, the use of hormone therapy drops and the fracture rate starts to go up, and just follow it along until you get out. They only went to 2008 on this. It gets worse and worse as you go on time. So within 2 years, the increased fracture rate was seen. It has persisted, and it's now affected, many millions of women who probably would not have had a hip fracture. The United States has the highest hip fracture rate in the world. 75% of hip fractures are in women, almost 300,000 a year. A quarter of those women die within a year. A third are in a nursing home a year later. This should not be going on. This is wrong. This is preventable. And we should be very active in doing something to prevent it. We also can look at the WHI findings with respect to heart disease, breast cancer, and death. The earliest of the reports, and what they do in the WHI papers is they really help us focus on the younger women. That in the women who are 50 to 59 when they entered the trial, there was a major reduction in myocardial infarctions, a 20% reduction in invasive breast cancer, almost a 30% reduction in mortality. Those are the findings in the women for whom estrogen replacement had a chance to provide the benefits it did when the women were premenopause. In the women who are older, that's another issue. We could have a whole session on the WHI, but I want you to know that there were WHI findings very early on, by 2003, that said, no, there's a group who are definitely benefited. If we look down the line at these women in WHI, the youngest of their women were aged 50 to 59. If we look down and we look at just the women who received estrogen, because remember, with endometriosis, those are going to be your patients of concern. The women who've had their uterus removed, had their ovaries removed, what happened if they were just given estrogen? And look at the long-term findings in these women: decrease in stroke and breast cancer, all-cause mortality, all cancer death, a 20% decrease, 26% decrease in diabetes, and look at the decrease in So the treatment there now, I understand you're going to say, well, wait a minute, for a woman with endometriosis, we may very well want to give her a progestin, and the data is not so good when you add hydroxyprogesterone acetate to Premarin. And that's true, but there nevertheless are some really important differences in their findings. The most important are the younger women who received estrogen alone. So WHI indicates that women aged 50 to 59 who initiated estrogen versus placebo had a decreased risk for decreased breast cancer, top of the list, heart disease, stroke, colorectal cancers, hip fracture, and death due to Alzheimer's disease. Now, the public has not caught up with that, and many in medicine have not caught up with that. But that's the long-term follow-up of the women when the intervention is made at an early enough age. I can't stress that enough. All-cause mortality has, again, a major reduction in those young women who received estrogen only. And it reduced the mortality due to heart disease, hip fracture, breast cancer, and dementia. But despite that, and this is why I put in this bottom line, only 4% of the women in the WHI continued ET, continued estrogen therapy. That's sad when you see that all of this reduction in mortality had occurred, but the women were so frightened and confused by the findings that they didn't continue. So there's this 4%, which means we have a major decline in the number of women, and boy, has that showed up, particularly in cardiology. I've spent 25 years of my life working in the Department of Cardiology and working with cardiac issues, and the change that's occurred in these 20 years is staggering. This paper by Aurora looks at it's called the ARIC study, ARIC, and it's saying the increase in acute myocardial infarction hospitalizations attributable to young women patients is staggering. The emerging data suggests a unique risk profile in women, hypoestrogenemia with adverse effects of a protracted dysmetabolic state. There are many, many papers that enforce this. And if you're not working in the cardiology field, you might not be aware of what's going on. Young women are coming in, they're all under the age of 70, and they're presenting with this. The situation reached the point where just a few, well, now it's 5 years ago, the American Heart Association came out with a very important publication, which is known about in the field of cardiology, but not so much outside. They made the following statement. Let's just drop to the bottom. The evidence supports cardiovascular benefit for menopausal hormonal therapy initiated early among women with premature or surgical menopause and within 10 years of menopause in women with natural menopause. So that's where the society is coming from. And this discussion, this particular publication, it's in circulation in 2020, really spells out the importance of estrogen from a cardiovascular point of view. When the first paper about women age 50 to 59, WHI paper about age 50 to 59, who received WHI, showed a major reduction in cardiovascular mortality, they published a number. They said, well, here's what we calculate was the savings for the women who received estrogen. It was 13 per 10,000 per year. But what we were able to do was to take that number and do a calculation on, well, how does that translate into the general population? And what we found was that because women had stopped taking estrogen replacement, young women, and again, this is just talking about estrogen after hysterectomy, by the time we had the data that we could put into our paper, which was a 10-year data, we calculated almost 50,000 women had died because they didn't take estrogen. 12 out of 13 of those women died from cardiovascular deaths. The rest from a variety of deaths. But bear in mind that since this paper was, this is a paper published in 2013, another 10 years have gone by, nothing much changed in the use of hormone replacement. And now the number can at least be doubled, if not increased more. Study after study, the Cochrane database shows women who've had bilateral salpingo oophorectomy under age 24, under age 45, if they were not treated with estrogen therapy, their risk for having heart disease and cardiovascular mortality is increased 1.67. If they used estrogen, it's decreased to 0.65. Big differences. And that, of course, is looking at the whole literature. The long-term follow-up in WHI shows the reduction in mortality. So if we go, and their more recent papers, the 2022 paper just confirms this. Paper after paper after paper. If you want to read a single paper, go to Saltpeter's paper in the American Journal of Medicine in 2009. That really looks at the whole literature on hormone and reducing mortality. You need to know this. This is, I think, very, very important. Bringing us up to date, this is a 2024 paper, which I found just fascinating because it's a study from NIH, and it's an 11 million women study. A 10 million women study in which they were able to sort out among these 10 million women, over 1 million women over the age of 65 who were using estrogen, mostly vaginal estrogen, and compare them to the women who were not. And look at what they reported. Risk reduction, go to the bottom of the slide. Risk reduction for breast cancer, for lung cancer, for colorectal cancer, for acute myocardial infarction, even for dementia. That's one of the most recent papers to know about. I think it's important. So when we look at this issue about estrogen and reducing breast cancer, again, study after study shows, and this is from the WHI investigators, Chilabowski and Anderson, and it's called Changing Concepts, Menopausal Hormone Therapy and Breast Cancer. And they say quite clear, women with prior hysterectomy did not, estrogen did not interfere with breast cancer detection and significantly decreased the risk of breast cancer. How many times can I say that? But I find I need to say it over and over again because it's been so deeply ingrained to be frightened about estrogen and breast cancer when it's not the truth. I already covered this in my earlier presentation, in my earlier slides. It's getting back to that study from Harvard where they showed that over half of all the actions of estrogen in a breast cancer cell was to induce the death of a breast cancer cell. And in fact, if you go to V.C. Jordan's work, I mentioned him earlier as one of the primary pioneers in the use of tamoxifen. He also writes in a subsequent paper that this action of inducing apoptosis occurs in women after they've been treated for breast cancer. And so the group, the medical oncology group at Southwestern in Dallas, actually had as their practice, just as the people at Harvard had for many, many years. After treating breast cancer, treat with tamoxifen or aromatase inhibitor for 5 years. And after that, give the women estrogen to prevent recurrence of breast cancer cells that were resistant to the previous oncology treatments. Now, what about hormone replacement in patients with a history of endometriosis? I am no authority on that. My experience has been that of any gynecologist who has the occasional patient with a history of endometriosis. The story I always told our residents was in one of our cardiac studies, one of the women who had severe coronary spasms and responded beautifully to just 0.6 to 5 milligrams of Premarin. Her arteries, we couldn't get them to constrict with no matter how hard we tried to stress it. But after 6 months of just the 0.625, this woman, who was 62 years old, had surgery at age 46, no problem with her endometriosis for 16 years. She developed an endometrioma in her rectovaginal septum, and I felt it. I could pinpoint it, and it was obvious. We had to take her off the hormone that was preventing her coronary arteries from going into spasm. But that's not what the literature says. So in preparation for this presentation, I went to 3 different reviews. There are more, but if you look at all these different reviews, you're talking about practically everything that's in the literature on the management of women, of menopause in women with a history of endometriosis. The most recent of them, the Zanella review from 2019, looks at just about everything. And they do come to a conclusion, and I copied it out for you. Most of the evidence studying hormone therapy in women with endometriosis is what's called low quality evidence. I loved one paper where they followed something like 80 women in a clinical practice, those with estrogen, those without, and only 3% of the women over a year's time developed endometriosis, had a resurgence of their endometriosis. I said, wow, only 3%. But that's what's called low quality evidence. But it does suggest that hormone replacement therapy can be prescribed to symptomatic women with a history of endometriosis, especially young patients with premature menopause. Continuous or cyclic combined preparations, or Tibolone, which unfortunately we don't have in this country. I was introduced to Tibolone in 1977. It's a wonderful drug. The Europeans use it all the time. We don't have it. Hormone replacement therapy improves quality of life. Symptomatic postmenopausal women, they should not be denied replacement therapy only due to their history of endometriosis. That's from the most recent review of everything that's been written. So let me conclude by saying estrogens have thousands of cellular effects in a woman's body, which maintain health and normal function. Estrogen deficiency due to natural or surgical menopause leads to symptoms, but also to diseases and increased mortality rates under the age of 70. Estrogen replacement therapy for women who've had hysterectomy is the only therapy that covers it all, controls symptoms, reduces disease risk, and reduces mortality rates, and it does not increase the risk of breast cancer. Avoidance of estrogen therapy is rooted in misunderstanding of research findings. As a result, there is unwarranted fear, and that's spelled out in the decline in use of estrogen therapy. But I must say, in the last 2 to 3 years, it has been changing, sort of a nudge in the right direction. I think it's important for you to be as informed as you can be about menopause and estrogen therapy, especially in the women you are treating. And there are a few places you can go to follow up on my presentation, because I'm really just touching the surface. I mentioned the book Estrogen Matters. Avram Bluming is a medical oncologist. He was at the NIH for many years, then became professor at USC. And I think it's a wonderful presentation. He spent his whole life taking care of breast cancer patients. Read his book. I would urge you to do that. MenopauseLearning.com is a website. You can go to that website, bring up the archives, and in that find a whole list of presentations like the one I just gave you that we have collected over the past 10 years. But the most recent ones are from last year, and they cover all the subjects we've been talking about, from changes in the bone to the heart. Dr. Howard Hodis' presentation is a wonderful presentation. Dr. Jim Simon's presentation on sexual dysfunction is a wonderful presentation. All of this is available to you. You just go to the site. There's no charge. You can actually apply for CME credit, but I'm not going to go into that now. Dr. Mary Jane Minkin is also a clinical professor at Yale. Um, she has a great series called ViewMedi. It's a ViewMedi series of short videos, and hers are on the menopause. Then there are two societies, the International Menopause Society, which by tomorrow, by the way, tomorrow, uh, that means March 12th, uh, is going to have a presentation on hot flashes. Uh, the menopause, but they have a library of videos. The Menopause Society used to be called North American Menopause Society, has a video series, but what they also have that you probably should at least have in your offices is their brand new edition called the Menopause Guidebook. And that's now the 10th edition. And that will bring you up to date on all the things that I've been talking about. So thank you very much for listening. I hope I have some impact on you and your care of the patients who have become menopause due to endometriosis and the treatment that's required for it.
Excellent. Can you go ahead and stop your share for just a moment?
Okay, so we made it within an hour.
We did, but we're still recording because I wanted to say something to our crowd.
So I'm going to say go stop share. Okay.
Yes, yes. So first of all, we forgot to give them a shout out in our sponsorship slide, but ViewMedi is the Endometriosis Summit partner, and they air the Endometriosis Summit when we're done with it. So props that somebody else has heard of ViewMedi. I'm very impressed there. We developed the gynecology department. Yeah.
That's great. I'm glad to hear that because Mary Jane has a lot of programs on the ViewMedi site. One's better than the other. She was one of my residents.
Yeah, we want everybody to go to ViewMedi. So my take home message while we're still recording is that especially for younger women, you need to start thinking of your long-term health when it comes to estrogen. And I hope that the other Dr. Sarrel, so not this Dr. Sarrel, that Dr. Sarrel, really drove that point home. We're talking about cardiac health. We're talking about breast health. We're talking about brain health. We're talking about bone health and so much more. I hope that everybody has the take-home message of how important estrogen is for your system. Right, Dr. Sarrel?
You bet. You hit it right on the head. Uh, and when you think about the 600 million years that estradiol took to provide biological existence, that's got to be central to your thinking about how to understand it and manage it.
Maybe we need an octopus as our icon now. We'll have to have, instead of this year we have our tiki torches, but maybe next year we have to have an octopus theme. Yes.
They're a lot smarter than we are.
Yeah. All right. And also, we may not have mentioned this amazing doctor. He is the founder of AHA. Can you tell everybody what AHA is?
AHA stands for Advancing Health After Hysterectomy. We started that in 2014, and it's a group of 25 leaders in the field. They're all highly respected and highly published. In fact, over the 10 years, the AHA team, individually and together, has well over 300 new publications in the medical journals. So their names you would know. But what we've done during this 10 years is to provide educational programs for healthcare practitioners, for doctors and nurses and PAs and DOs who are seeing menopausal women and giving them the tools for understanding evaluation and treatment, and also resources at our website in the form of videos, but also the library has a great deal of information about menopause. And the reason for AHA was that when we started, we had the data from the Women's Health Initiative on estrogen lower in the women aged 50 to 59, lowering the risk for heart disease and breast cancer. We knew that was safe. Because remember, 2013, 24, our paper on how many women died, the paper that was in the American Journal of Public Health, that came out in 2013, maybe 2014. But in those days, we were sort of like, you know, alone in the wilderness with very few people paying attention. No one wanted to hear about hormones at all. At Yale and most medical schools, they stopped teaching anything about menopause to this day. And that was a very sad mistake. But, medical history is strewn with sad mistakes. Think of what Yalo had to go through just to get radioimmunoassay accepted. Uh, think about the work on the estrogen receptor. People thought he was coming from Mars with that. He knew exactly what he was talking about. So we go through our ups and downs in medicine. We get wedded to ideas, and then we can't get out of those ideas. But you got to have an open mind. I've been in a medical practitioner now for 65 years. So I'm old enough to look back on this period and say wonderful things happened in medicine, fantastic developments. Just have to have an open mind and be willing to forge ahead.
Yes. Now, you also have a film out there. Do you want to tell people very quickly about the film before we sign off?
I'm not sure. We have quite a few films, so
Oh, well, we remember Hot Flash Havoc very passionately.
oh, all right. Well, that was made quite a few years ago, and you can see by looking at it how timed it is. I in that film, I take the same position I've taken today, but people are not as bold as I've been in this presentation. But of course, I've had a lot more ammunition now. I have all those long-term findings of the Women Health Initiative in which they show what said originally was not correct. And
Yes, Sorrel is very shy and reserved when it comes to educating on women's health. Also, for our watchers out there, if anyone wants to reach you, how can they do that? You have a website?
um, no,
Well, who returned? Is their email to menopauselearning.com?
uh, no, that's a very good idea. It's one of the ideas we've talked about. Um, I've been open to letting people refer their difficult or complicated cases to me just to go back and
No,
forth over.
not cases. I'm talking about our podcasters, our filmmakers, people who want to educate others. I think they may be reaching out to you. That happens from the Endo
Well,
Summit.
that's simple and straightforward. That's just phillip.sarrel@yale.edu.
Excellent. Remember, because the Endometriosis Summit, we let you talk about theory, but we don't let anybody talk about cases. So we're wrapping up. I want to thank you so much for being here with us and take care.
Okay, thanks for inviting me.